Let's get started so we have plenty of time to discuss some interesting cases. So tonight we're talking about pelvis fractures. Thanks for joining the AONA Link team. So we went through this before. You all have been here along the way and already know what AONA Link's all about. We're really appreciative of the support of both Doctors Rout and Dr. Aker. Dr. Aker's with us tonight. Dr. Mitchell's on the keys, answering all your questions. I'm going to take you on a journey through pelvic ring injuries tonight. We're really excited about our guest faculty tonight. Dr. David Zolzer comes to us from Virginia Commonwealth. Dave, do you have any advice for students as they begin to make their rank lists?
Yeah, thank you guys for having me. It's nice to see so many bright young minds, the future of our profession tuning in. Um, Making the rank list, I couples matched. My wife was going into anesthesia. And so if you're couples matching, my advice to you is probably do whatever your spouse says, and everything's going to go well. If you don't, you're going to hear about it for the next 5 years of your life. It's the best thing I can do. If you're not in a couples match, then go be wherever you want to be and enjoy your 5 year experience. No matter what, it'll probably go well. My wife and I went off a gestalt of sort of what felt right. Having never spent time in Lexington, Kentucky before, but just kind of liked the program, and it worked out great for me. So I wish you all the same success.
Yeah, I think that's sound advice. Don't try to play too much of a game. The process is meant to benefit the applicants, so don't overthink things.
Do what feels right.
Yeah, there you go. So we've been on a journey through all sorts of injuries tonight. We're talking about pelvis fractures. Don't forget to check out AO Milestones coming at you soon. And then we really appreciate all the engagement, so keep it up. Ask questions in that Q&A box. Dr. Mitchell will be there waiting eagerly to answer all your questions. Don't forget to claim your badge and watch on YouTube later. Quick recap from last month. I was bummed I missed out, but you guys talked about upper extremity fractures and how some of these can be managed without surgery, thanks to some of the studies that Dr. Sarmiento did. There are some that do benefit from surgery, and you talked a little bit about those indications. We also reviewed some of the things from our earlier lectures on how you fix fractures and stick to the AO principles while achieving either absolute stability with compression plating and primary bone healing, or bridging type constructs with relative stability and secondary bone healing, as shown in these examples. And then you also touched on the anatomy as it relates to the upper arm and how the radial nerve is at risk for injury in your approaches and with the fractures themselves. And that articular injuries, like those in the distal humerus, require articular reduction and absolute stability at the joint, and sometimes bridging in the metaphyseal region. And when you approach those injuries, you're working around the triceps and navigating the ulnar and radial nerves. We continue, pardon me, we continue to lean on our principles as we navigate all these cases. Tonight, we're talking about pelvic ring injuries. And so, these can be complex injuries and can be an overwhelming topic at the training level that many of you are at. And so we tried to distill this in a way that it's digestible. And so hopefully things come across without getting you too overwhelmed. So the learning objectives tonight, we're going to cover the imaging as it relates to the pelvic ring. We're really going to harp on some of the important anatomy as it relates to the pelvic ring as well, specifically some of the associated injuries that we can see, and then talking about classification and mechanisms of injury and how those are linked much of the time. And then we really want you to be prepared as you begin to see these as consults, as you help out on call, and begin to have sort of a foundational understanding of how you can approach these injuries in the emergency room, because it's one of the rare occasions where we as orthopedic surgeons can help save patients' lives. So the osteology of the pelvic ring is pretty complex. And so what I would say is I would really encourage you to get a pelvic model, take a sawbones and put it in your hands and spin it around and look at the features, because there's so many fine details to the topography of the bone itself. And look at a textbook as you do it and kind of use both that tactile sense and visual sense as you read through the chapters. But really the bone of the pelvis itself is made up of the sacrum and the two innominate bones, which includes the ilium shown here in blue, the sacrum in red, and then the SI joint joins those structures, highlighted in purple there, and then the acetabulum or hip socket is part of the pelvic ring, but sort of a different nature of injury, which we're really not going to venture into that territory because it can get even more complex. We're really focusing on injuries to the ring itself, and then the pubis and ischium are towards the front of the pelvis. The ligamentous anatomy is also important because it has correlates to how we think about stability in these injury patterns, specifically the pubic symphysial ligament in the front, the sacrospinous ligament connecting the anterior sacrum to the ischial spine, and then the sacral tuberous ligament connecting from the posterior sacrum to the ischial tuberosity. And then the SI joint has ligaments both in the front and in the back that are really important for stability. And the iliolumbar ligament connects the sacrum to the L5 transverse process. The radiography of the pelvis can be complex because of that osteology. Here we can see two versions of an AP pelvis. One is an injured side, and one is a what we call a ghost construction of a 3D image of a CT scan. But I played with a bit to try to get you a good AP view here. And some of the things you really want to look for are that the coccyx is right above the symphysis, that you have symmetry, generalized symmetry between the two sides of the pelvis. You can see that here in the teardrops in the obturator foramen, as well as the spinous processes being in the midline and aligned with the symphysis here. On the injured side, you can see that those relationships are certainly disrupted as you see asymmetry in the obturator foramen. You see a widening of the symphysis, and you can see some fractures as well. We also use other views to assess pelvic ring injuries. These include the inlet and the outlet views. These are taken with the C-arm tilted or canted either towards the head or to the foot. I think of an inlet as looking into the pelvis, and an outlet as you're outside the pelvis looking into it or at it. And these help us gain other information, such as in an inlet, we're looking at posterior or anterior displacement and changes that cause translation within that plane. And on an outlet, we're really looking at cranial or caudal displacement. Dave, when you're looking at pelvis fractures, what are some signs that you have a good inlet or a good outlet in your mind?
Yeah, it's a great question. I think the first place, if you actually go back maybe 2 slides,
Yeah.
the first thing I'd say that I try to train my eye to start looking is at the spine. You kind of with your animation, you kind of drew it, but if you start at the spine, kind of go to home base, you start to understand whether what you're seeing at the pelvis is real or is because you're looking at some sort of oblique radiograph. So we'll see lots of future X-rays with a lot of deformity in the rest of this talk. And so if you start with the spine and look at find the pedicles, the spinous processes, and look at how centered the spine is, that can be a good initial place for your eye to wander to see whether the deformity that you may see at the pelvis is real or whether we're looking at a sort of non-ideal image. And then if you go forwards then to our inlet and outlet, because those are at the same plane, you see that the spinous processes, the pedicles are kind of still balanced on those views. So that doesn't really change. We're changing the tilt of the beam towards the head or away from the head with the inlet and outlet respectively, but still start there. And then if we're talking about what makes a good inlet, if you look at that top right image, especially that ghost reconstruction that Taylor was talking to, so that's a 3D kind of put into the perfect position. And I can't trace my cursor, but maybe you can, Taylor, this really crisp cortical line that you see coming, and it kind of looks like a very shallow M at the top here towards the sacrum. If you show that anterior, that's the cortical density of the anterior sacrum that Taylor's tracing there. And if you see, it kind of looks like a very, very shallow M. And that's a really good sign that we're looking and lining the bone, the cortical bone of the two upper spinous processes are kind of superimposed on each other, and it's getting really dense. And we see that. And then if we look at the outlet, that's a little bit easier to see. We want to align the pubis. A lot of people use the second sacral body as a general guide. People can debate that, but we want to basically be looking down the neuroforamina. And so if we look at the foramen on S1 on both sides, we see that instead of looking at them obliquely, we're starting to turn them into round circles. And so that's a pretty good clue. But just broadly, if you're standing back and looking at it, the pubis is starting to get lined up with the second sacral body is a good starting point probably for you all.
Yeah, and I think it's important to note that the image I showed 45 degrees in either way, but these can differ between patients. There's tremendous variety. One other thing we want to point out is that Judet views of the pelvis are generally utilized to assess acetabular injuries, and it can be sometimes confusing, especially when you're an intern seeing these consults in the ER. You may want to order an AP, an inlet, an outlet, and Judet views. But sometimes the Judet views may not be necessary and may be an extra cost or cause patients extra discomfort. But these are views that are taken at an angle with the patient tilted, so more from the side, and they create oblique images. An obturator oblique gives you the obturator ring staring at it in fosse, and then an iliac oblique gives you the iliac wing in fosse. And so these are really views that we're looking at the hip socket rather than the pelvis, but we do use them as we treat pelvic ring injuries. But that's just one of the distinctions we want you to keep in mind as you assess these injuries. The anatomy of the pelvis is really complex. We said the bony anatomy was challenging to navigate, but the soft tissue anatomy and neurovascular anatomy may be even more challenging, and that's why these are hard to treat some of the time. You can see all the structures here as they are intimately associated with the bone, specifically vascular structures. One of the things we'd like to highlight is this connection that you sometimes see. It's an anastomosis between the external iliac and obturator uh, systems. And sometimes we encounter this during our approaches, and it's called the corona mortis. It's one of those pearls that we'd like you to have in your quiver there. But you can see the proximity of the obturator vessels, the external iliac throughout your approach, and they're intimately associated with the bony anatomy as well. The nervous anatomy holds the same idea true here. You can see the lumbosacral plexus is nearby. And then in the posterior side of the pelvis, you have the sciatic nerve. And in the anterior pelvis, within some of the approaches, we may encounter the obturator nerve. And then often, as we put in sacroiliac screws, we are always thinking about the L5 nerve root as it could be potentially injured as it drapes over the front of the sacrum. And then the genitourinary structures, as well as GI structures, are very close to the bony structures. You can see where the symphysis is in this diagram. It's really close to things like the bladder and the urethra. And it's not uncommon to see injuries to these structures that impact how we treat them. So that was a lot to run through. Are there any questions that popped up, Phil?
Nope, we're good.
No, we're good. We're good. All right, let's dive into
Taylor, I'll
our.
I'll just say
Oh,
real
yeah,
quick,
yeah.
gosh, you just gave him so many pearls right there for students that are about to maybe go on rotations next year or embark on some orthopedic rotations. The difference between the AP, the inlet outlet, the Judet obliques, those are very common questions on rotations in the operating room on morning rounds. You might get called on. So knowing the subtleties of what we're looking at, what those show, those were some really good pearls there. And last but not least, I'll just say that as a medical student, I know that looking at pelvis X-rays was a real enigma for me. I mean, it's so complicated that it's easy to just think, you know what, I'm going to end up going into sports medicine someday. Like I don't really need to learn this stuff or know this stuff. But I promise you, the longer that you look at them, the more reps you have, the more you see AP pelvis X-rays on morning report at rounds, the more you'll start to recognize what normal is. And then it becomes easier and easier to recognize what's abnormal. But you have to look at hundreds, if not thousands, of normal X-rays before you start to see. I mean, this one you have on the screen is pretty obvious that there's something wrong. Sometimes they're not so obvious. So the more your eyes see, the better. That's it.
And the sports surgeons, they're going to be treating some avulsions from the pelvis too, so they got to know those things nonetheless. So you can't escape it. So first case here, we've got a male in their mid 40s, status post motor vehicle collision. They come into the trauma bay, and this is the AP pelvis that the team gets. Dave, what are you thinking when this comes in your trauma bay? How's it work at VCU? Are the ortho residents there at the trauma activations, or how do things sort of proceed with a case like this, who's actually hemodynamically unstable from the history here?
Yeah, I think so. A couple questions there to parse out. So I think our residents are certainly on the front lines, and I think most every trauma center is going to be a little bit different. At every place I've been, I think orthopedics has not been a required participant at the initial ATLS activation. You don't hold the pager that goes off that says, the Delta is coming in. You need to be here now. But I think most of the time our residents are working down in the trauma bay. They're immediately around, and you sort of, people will stop you, the x-ray techs, the general surgeons, the nurses at the trauma activations will let you know, hey, we got one for you, and it's a real, injury. Or maybe you just kind of poke around. And I think I always encourage all residents to poke around these injuries and sort of run at these problems. This is Taylor talked about this earlier. This is a orthopedic life-threatening injury that we as orthopedic surgeons are uniquely qualified to help. And so for you guys that are early residents, maybe you're interns, or maybe you're a fourth-year medical student about to be a resident, this is going to be you on sort of the front lines, going and actually, saving someone's life, doing something we don't get to do a lot as orthopedic surgeons. And so I think for most of you, it'll be the general surgeons, maybe anesthesia, nurses, and the emergency department will be a part of the initial trauma activation. But then you'll be right there, assisting. And I think, starting with the ATLS workup, being there to help guide placement of pelvic sheets, applying skeletal traction, recognizing these injuries early, and then knowing how to, immediately respond. This is the sort of thing that you're going to save a life if you know what to do here.
What are some of the things on exam that you're advising your residents to look out for that are not often readily apparent per se?
Yeah. So I think, as they're stripping the patient down naked, they're starting their initial activation. I think we're looking for signs, contusions, swelling around the perineal area or the lower abdomen, the flanks. We're looking for signs, was this patient struck? Did a tire roll over their belly? What's the position of their legs? Are they sort of splayed out into this this open book manner where everything is kind of externally flopped open? Are there any open wounds in this area? Any bleeding from either the penis or the vagina, from the rectal region, that alerts you to a really severe dramatic injury like this? And then encouraging them that the part of the ATLS evaluation is an AP pelvic radiograph like you have here. And just with a radiograph like this alone, you have enough information to do immediate life-saving, provide immediate life-saving care.
Yeah, exactly. Those are all excellent points. And certainly placing a Foley, looking for blood around the penis, like you said, are important, or blood in the urine. And then, like you said, this is a chance to save life. And that's how we manage. One of the components of your ABCDE survey is managing circulation, and we can help control bleeding. And also, one of the things to point out here, you said this x-ray gives us a lot of info. There's some real subtle things, like one of the things you highlighted when you sent me this image, this air down here near the hip. We'll get back to that in a second, though. And so, like you said, applying an anti-shock sheet helps control volume of the ring. Often we see that bleeding in the ring is venous related, and by controlling the volume, we can have a tamponade effect to help slow down some of that venous oozing that we see. And so here you can see a sheet was applied in this example, and it closes that volume. You see this distance at the symphysis is much smaller, and then this volume is also smaller. So that's how we control hemorrhage. There are some really nice articles that highlight how this is done. How do you have the residents do it at VCU? Are they, um, this example shows 2 clamps. I've seen examples of 4 clamps. Is there like a protocol that you guys use, or
Yeah, we use bed sheets like you have drawn here. Every institution's different. Wherever you go to work, you're going to want to find out, do we use binders? Do we use sheets? Does EMS often apply them in the field? That tends to be something that happens now if there's suspicion of these injuries. But here we use bed sheets, and we follow a protocol very similar, which is for the orthopedic resident to be a part of, alerted very early in the trauma activation, and to help guide the sheet placement if they're present. And if not, my partners and I will educate the general surgeons on how to apply these sheets once a year to the new oncoming trauma surgery residents. But it's a 2-man maneuver. A sheet is very adaptable. You can do this with a lot of simple equipment that you have, and it's obviously very cheap and extremely effective. And so I encourage everyone to read this paper you see on the right after this webinar, and make sure you kind of understand this technique.
Taylor,
yeah,
it's
for
pretty
sure.
common in Houston for a patient with, the obvious external rotation, swelling, a very swollen scrotum that has an obvious pelvic ring fracture to arrive in the trauma bay with a binder already in place by EMS. Hallelujah. However, we always encourage our residents to unwrap your Christmas presents, unwrap your presents. So the patient is not going to suddenly exsanguinate from taking off the binder or opening it up, because you need to know what type of wounds, what does the skin look like. You need to do a rectal exam. There's a lot of information that can be gleaned from visualizing and examining this region. You can't just leave it tethered up underneath a sheet or a binder. Once that examination is complete, right back to what Dr. Zolzer said, get them wrapped up and snuggled up and off to the scanner or onto the next portion of the evaluation.
For sure. And one of the things that we harp on our residents about is if you loosen it, you take it off, you don't leave right away. You got to watch them, make sure they remain stable during that quick assessment, like you said. For
One
us,
follow-up to that, Taylor,
yeah,
if I
yeah,
may,
for
which is
sure.
a great question. Annalisa, are we obtaining an AP X-ray before and after binder placement, or is it first priority getting the binder on, thus X-ray only after? So I think it's going to be a little bit case by case basis. If they come in the binder and they're an extremist, sometimes you just let trauma do their thing, do the resuscitation, you get out of the way. But there will be a time, to Dr. Akers' point, where you'll need to assess the patient. That may involve loosening the binder and assessing for wounds. You'll have an idea that by that point, they often will have a traumagram, a CT scan. You'll be able to see if they have a pelvic ring injury. So this will be a pretty rare situation, but in general, you're going to get an AP pelvis before. You'll apply your sheet or binder, and then really want to emphasize you're getting an X-ray afterward. It's just like doing a reduction of a distal radius or a elbow or whatnot. You want to see what you've done, that you've achieved your goals. And then an anonymous person asks, is there a pathway to get ATLS certified as an orthopedic surgery attending? And the answer is yes. So many of us are.
Perfect. And like Dr. Akers said, sometimes patients arrive in a binder at Houston. Commonly out here in El Paso, people are in binders. Not as often are we seeing sheets used. And this is an example of what a binder looks like. There are other techniques such as internally rotating and taping of the legs or the feet or the toes. Really, that internal rotation moment helps control that volume in it and of itself, even if you don't have the sheet or the binder, although most are readily available. Here's a couple examples. The binders are convenient, but sometimes they're applied inappropriately or in terms of how it's applied and whether or not it's even needed. And so in the first example, you can see extremely wide ring that closed down very well in the binder. The binder's a little bit tilted there and maybe a little bit high. The key is you want that down near the trochs, but it's doing some good work nonetheless. The other example shows a ring injury that maybe the binder is not even really needed, and it's also applied high. And so you want to be able to recognize that and adjust and get that down lower towards the greater trochanters. We also have some other strategies that we use to control hemorrhage when patients are in extremis. Like we said, sheets and binders are first step. And then sometimes you need to send the patient to interventional radiology so they can perform angioembolization and stop bleeding in that way. And then pelvic external fixators are sometimes used, and pelvic packing is a controversial subject, but also sometimes used in extreme cases. What's your experience with some like pelvic external fixators and packing? Um, some people might say that there's really almost no indications for a pelvic X fix, like a sheet or a binder is usually going to do the job better.
Yeah, I think this is another one of those. Every institution is different, and everybody has uh, different emotions about some of these topics. Um, my first job, we very rarely did pelvic external fixation, except for very specific situations like patients that have scrotal or penile or vaginal injuries, perineal wounds that need to go into like lithotomy position, or they have contaminated open wounds or genitourinary problems in the front of their pelvis. And so that's not every pelvic injury. And so other jobs, the job I'm currently at, the trauma surgeons have sat down with us and come up with specific protocols they've liked followed. And one of those is that if a patient's in the operating room with any type of unstable pelvic ring injury, their goal is to get the sheet off early. And so they want us putting either what people call shock screws, which is some iliosacral screws in the posterior pelvis to stabilize things temporarily, or external fixation. And then some of these other topics like pelvic packing and angioembolization are really considered sort of adjunctive things. And some trauma surgeons that are really the ones guiding these initial steps with our assistance may be quick to jump to some of these things if they don't have experience with pelvic sheets, or they haven't seen the dramatic effect that just containing the volume can have to aid in patients' resuscitation. And so if you are working with someone that maybe isn't as familiar, like some of our general surgery colleagues may be with some of these injuries, encouraging them to be very algorithmic about initial resuscitation, controlling volume in these injuries with a sheet or a binder if it's appropriate, and then using some of these other things like external fixation, angioembolization, or pelvic packing as secondary sort of next best steps.
Yeah, I think that's very well put. So back to your patient here. They're now hemodynamically stable. The sheet has had good effect. These are the AP one more time, and then some more recon images of the inlet and outlet projections. How do you like the students to begin to talk about these X-rays or these views when they're presenting them to you?
Yeah, there's all sorts of classification schemes you all will learn, and some of them are very, very good, and a lot of them are used. I would really I try to encourage the residents to really start just say what you see and localize the points of instability. So find out what is injured. And so there's a lot of ways you can describe this injury. Many people would call this an APC type injury, an anterior posterior compression type injury that results in an open book injury to the pelvis. I would just encourage everyone to just say, this is a traumatic symphyseal disruption. I can tell that the symphyseal ligaments are torn, and I would say this is a left sacroiliac joint injury. And by just saying the sites that I see the injury, I start to develop my initial treatment plan. And I think it's something very elementary that everyone in the room can really understand and sort of put us all on the same page instead of start using all these eponyms and different classification schemes that some people may or may not be familiar with and may be a little bit subjective.
Yeah, that's excellent. Yeah, describe what you see. Sound advice for dissecting those kind of complex images. And then we always get CT scans in these injuries, basically to further assess that complex bony anatomy, but also to highlight soft tissue issues that are not elucidated in radiographs. Here, you had a really nice example. We showed that circle on that initial AP pelvis, showing that air, and you can see how that air translates on the CT scan. What did you guys find here on exam? And I guess what how would you describe what we're seeing on the CT here?
Yeah, so what we're looking at here is a massive traumatic hernia that is going all the way down into his scrotum. If you look at that image on in the bottom right, that is his omental contents, sort of filling his scrotum. And if you look at the top part, you see that is one of his testicles really being squashed at the top of that by the volume of bowel contents that have displaced into his scrotum. So a really pretty dramatic injury. I think this is a good case illustration to say, you know, you gotta assess the soft tissues. We get so hung up sometimes on the bony injuries, the deformity. It's easy, right? It draws your eyes to it. When you see like an open book injury like this or a traumatic symphyseal disruption, and you may start sort of getting this tunnel vision on, we got to get stability, we have to do this. But starting to train your mind to look at other things. If you look at this image on the bottom right, the CT scan, that's a different window. So when you look at a CT scan, you can change the window of the CT from a bony window like you see on the other three that really bring the bone into contrast to the soft tissues, to then a soft tissue friendly window like you see in the bottom right, where the soft tissues really stand out and you can really see the different planes, see air densities, see all these things that may or may not be visible. If you look at that image on the top left that's in the area of the circle, you may or may not be able to tell that there's even a soft tissue injury there. But if you looked at that on a soft tissue window, I bet it would jump out at you.
Yeah, thanks for highlighting that about the soft tissue window. That's an important sort of technique to utilize when you're looking at the CT scan. So just to go back to the recon image here, showing the injury, and then with kind of jump ahead to your fixation construct, I think really the key here is that we're restoring anatomy and restoring stability. But what was your sort of surgical plan as you approach this injury with respect to the soft tissue problems?
Yeah, and so this is really, you know, a lot of this is so much fun because it's really a team-based approach. And so this is something that, you know, the different elements of this guy's injury need to be recognized early so that things can be sort of planned in the right way. And being recognizing the both soft tissue injury, this massive traumatic hernia, and how that impacts, because the general surgeons need to get access to this area. So they need to do an exploratory laparotomy and they need to do an approach into his groin in order to deliver and reduce that bowel content back into the abdomen. And then I need to do my job to help restore the stability of his musculoskeletal injury. And so this is something that you want to talk to them as early and often as possible so that you both understand each other's approaches, each other's treatment strategy. And so, you know, I asked them to keep their exploratory laparotomy incision high, you know, way up by the belly button to stay away, and then was there to help guide them when they did the initial, you know, where are you making your groin incision? Okay, that'll be good because my incision will be here, and actually drawing it out on the patient before they start so that they know what my plan is. So he went a few hours after he arrived with general surgery for an XLAP and to have a reduction and repair of his hernia. And then the next day, you know, he was kept in the sheet until the next day after that. And then I followed and did what you see here on the right.
Excellent. Yeah, I mean, communication is really key in these complex problems that require a multidisciplinary approach. Case two
Taylor,
is
I
a little
think
bit. Oh yeah.
also a good point. And now, just as we're getting into all these cases, I would say from a med student transitioning into an intern, junior resident level, all all of these injuries require emergent attention, but not necessarily an emergency operation. That's different. This is an evolution. I can't believe I'm saying that I'm as the old guy in the group, but when I was a resident once upon a time, these would often get an external fixator overnight, or certainly the next morning they would get an X fix. And then we would wait 3 to 5 days to let a hematoma form, let the clot form, let the bleeding subside before doing a fan and still, before doing an open approach. There was some thought that we needed to let all the inflammation kind of simmer down before opening these up. Just so interesting how there's been such an evolution of care over the last 15 years. Emergent attention, absolutely. Not necessarily emergency operations. Phil, what do you think about that? You agree with that statement?
Definitely. And I think a lot of these require collaboration, and that means communication and sequencing and timing, and urology's involved and general surgery and who goes first and these types of things. So certainly stabilizing them first hemodynamically, this is our opportunity to save a life, and then taking a step back, absolutely. So.
Perfect. Yeah, that's really useful insight because I think we'll show some good examples of how far that's sort of swung. That maybe you don't even need to really open them up anymore. That you can do things with really small incisions. So this is our next example here. It's a little bit similar, but also very different in some ways. Uh, this is a mid-50s male. He was in a motorcycle collision, and you can imagine, based on the mechanism, it's really important to think about how that happened and that part of the history. Because you can see here, you can imagine somebody doing a big split over a motorcycle here. You can see a sheet's been applied again based on those clamps that you see there, but that it closes the ring a decent amount, but not quite all the way. And so one of the things, can you take us through what you saw here, Phil?
Yep, absolutely. I'm going to go through 2 questions about pelvic sheets and binders as we're talking about this. One question was about transitioning from a binder to the sheet, particularly if it's going to be on long term. And I think that's a great question. My preference, if they come in a binder, and often we'll leave them in the binder until they get stabilized, prefer a sheet, particularly for long durations of time because of the skin, which is the structure that you may be worried about the most. So you can certainly have skin issues if a binder's on for a binder or a sheet are on for a couple of days. So that often requires reassessment. And then Jake asked, are there contraindications to using a pelvic binder or a sheet on a hemodynamically unstable pelvis, which I don't think I've ever been asked before. I don't think there's a contraindication I can think of because we're in life-saving mode. So at that point, the sheet goes on, and then we close them down, they get stabilized, and we kind of move from there. I can't think of one. Tim, you
Maybe
got any contraindications?
if the sheet is somehow covering something up that is even more life-threatening than the pelvic ring injury you're trying to treat. That's pretty rare. An aortic injury or something like that, and they can't access it to get to it because the sheet's in the way. Something like that, but that'd be extremely bizarre.
Oh, I think that when you're starting to learn all this stuff, perhaps, some sort of acetabular fracture where you can wrap up the pelvis and you're really squeezing the femoral head into the pelvis to kind of a protrusio subluxation. I can see how that in the early goings would be like, oh man, I just messed up. Look at that x-ray. I wrapped him up in a sheet and now it looks terrible. I can promise you're not doing any more harm than the truck that hit him at 80 miles per hour did, So if you see that, then it's always easier to relax the sheet, relax the binder. If you think that you've created a potential problem, but no, I would say no. It's rare to find a contraindication to try to perform a relatively benign external life-saving measure.
Yeah, so this case is going to be about the associated injuries that can come with these pelvic ring injuries. So this is a cystogram, and so a wise man once told me that imagine my head is the bladder, and the top of my head is intraperitoneal, and then my face and everything else is extraperitoneal. And This is a bladder disruption that went into the peritoneum north and then extraperitoneal everywhere else. So that's why you kind of see contrast everywhere. And so this is where the multidisciplinary comes in, and we pair with our urology colleagues to treat this injury. CT scan shown here, so a little bit different than the last case. Instead of a sacroiliac joint disruption, so a ligamentous injury, this is a sacral fracture. So similar mechanisms, but different injuries. And in this case, that bottom right picture to what Dr. Zulzer was saying, that's showing the soft tissues, and that white contrast through the sacral fracture is a urinogram of the sacral fracture. So that's from the cystogram, residual contrast bathing the sacral fracture.
How did that change your surgical strategy? Like, because of that, is it going to need an X-fix sort of thing, or where are we at with that?
That's a great question. He came in critically ill, and so he got wrapped in a sheet and then was cleared for surgery. And so as long as I have my team, I've got my urology team, I've got trauma clearing him for surgery, and I've got a plan to fix this, and he's stable enough to undergo an open operation. He's going to get clamped in the front at the symphysis, and then we're going to use a screw in the back posterior pelvic ring to compress his sacral fracture, and then we'll eventually plate his anterior symphysis. And so in these cases, we approach, it's, orthopedic trauma surgery. I didn't think I would be operating around the bladder, but we get to, and we approach, urology comes in, they fix the bladder, we clean everything really well, change gloves, gowns, the whole thing, and then we do our portion and put in metal and fix his pelvis. And I think coming back to the associated injuries, Taylor, this is the portion of our lag screw that's applied. So here we see a partially threaded screw. We talked about this in the implants talk, but we see threads only on the terminal portion of the screw. The washer hits the ilium, and the sacral fracture compresses.
You can see you got a nice. Oh, go ahead. Sorry.
I was going to say, I used to work with an anesthesiologist in my last job who's he's getting up there into his 80s, and he's still in practice, and he's a pretty remarkable guy. And he liked to come into some of the pelvis and acetabular cases I was doing, and he'd look at where I was making incisions and the sort of stuff I was operating around, and he'd be like, "This is an orthopedic case." So it's a lot of fun when you're in orthopedics and you get to operate around the bladder and the chitlins and all that stuff that not a lot of our colleagues get to do.
Yeah, so this one, the screw did accomplish a really nice reduction for you. And like you said, we talked about this before, a little bit of a throwback. That's the partially threaded screw, lag by design, and it compresses across either a fracture or the sacroiliac joint as shown here. And you can see the difference between the fully threaded and the partially threaded screws. So then your final construct looks a little bit similar to Dr. Zolzer's construct with the screws in the back and the plate in the front, even though there were subtly different injuries. And like you said, the urology team came in and repaired that bladder injury in this case. So just a quick recap, we covered a lot there. Anatomy is really power in these scenarios, and quality imaging is really critical because of the complex soft tissue and bony anatomy. And then the ER management can be life-saving, and that includes ATLS, your ABCDEs, you control volume, you control bleeding, you use binders, sheets, and traction, and you look for associated injuries, and you talk to your other teammates because trauma is a team sport. So then we'll dive in a little bit into some classification talk. Before I do, any questions, Phil?
Yeah, I've got one I want to answer. This is Alan. Great question. How do pelvic fractures fall on the spectrum of damage control? Does percutaneous fixation still increase the risk of second hit? And great question, because often our trauma colleagues don't know what we're planning to do. So they don't know the difference between an 8-hour both column acetabulum and perc screws for a non-displaced sacral fracture. So that's where the communication comes in. And some of these can be resuscitative. So you put in a screw like that last case and reduce a sacral fracture that's massively displaced, you're going to decrease bony bleeding from those that sacral fracture as well and close down the pelvic ring. So in my mind, that's more of a resuscitative case, much less of a second hit if you're doing percutaneous type techniques. So that's great question.
So yeah, probably the most common classification system we use as we talk about these injuries is a mechanistic classification system that's called the Young and Burgess classification. Dr. Burgess was most recently at Houston. And so Dr. Burgess described these injuries in conjunction with a radiologist, I believe. And that's why the original article is in a radiology journal. But we talked about some of those forces that we were describing as we dissected some of those first cases. So the Young and Burgess includes 8 different types. There are 3 anterior posterior compression mechanisms. They go from APC 1 to 2 to 3 based on the severity. So an APC 1 just has a symphyseal disruption, APC 2 symphyseal disruption, and then the SI joint on the left side of this image here is disrupted, but the posterior ligamentous attachments remain intact. There's a hinge there. And then in APC 3, that whole hinge is disrupted. It goes all the way through, disrupting both anterior and posterior components of that SI joint. And then lateral compression injuries, or a force directed through the side, results in a compressive fracture, usually resulting in a fracture at the ramus, either superior or inferior ramus, or both, and then a fracture in the sacrum. That as the sacrum internally rotates. You also see what we call a crescent fracture. That is that intact portion of the ilium that's connected to the sacroiliac joint back there on the LC2 injury. And then in LC3, that left-sided hemipelvis internally rotates so much that it causes a injury on the other side. That's usually an APC variant of an injury. Another type within the classification is a vertical shear injury, which involves that more cranial translation through disruption of either the SI joint and the ramus, or the sacrum and the symphysis as possibilities as well. And so this is our third case, which is an excellent example of this. And you look at that mechanism, right? This is a skydiver. And so that force is translated likely in a vector that's causing a vertical displacement of the hemipelvis. And you can see that here based on these lines. That symphysis doesn't line up anymore. That sacrum doesn't line up. And then there's also a little clue that there's an avulsion of the transverse process of the L5 vertebra. How do you treat this injury differently from the last, Phil?
Yes, there are some unbelievable questions coming through the chat room. I'm gonna hit.
I
I'm
was
gonna
just
hit
going to say, holy cow.
on
I
the.
was reading some of the questions, some of the answers. These students are fantastic.
Yeah,
Really. Wow.
this is good,
Nice,
and this
nice,
this
nice.
case will cover it both. So one question was about nerve injury and with sacral fractures, and so this is a pattern. This is a location too, a zone 2 sacral fracture, zone 2. That's right through the neuroframing, where a lot of the counseling with him before surgery was about his nerve, about foot drop and the possibility, and his nerve is around that. He did not have one. The last patient with a sacral fracture did. He had a complete foot drop that still hasn't resolved 2 years later. So definitely a concern with this. So that's first. With this fracture, instead of a sheet or a binder, we're going to put this patient in traction on that side. We're going to take x-rays to see how we do as that hemipelvis comes down. And then this patient will be treated with percutaneous screws. And then another question was the sequence. They saw the questioner saw 2 screws, a partially threaded and a fully threaded. In this case, we'll have that, Taylor. You can go forward, I think. Well, so this case has it. And so the question was, which screw gets placed first? And it's such a great question and a very important question. And the partially threaded screw gets placed first because that provides the compression as the fracture is lagged together. You can imagine if you put the fully threaded screw, the fracture would not compress because there would be no non-threaded portion to allow that to happen. So partially threaded first, the lag screw is additional fixation as threads through the ilium, the sacrum, the SI joint. That's a lot of points of fixation, particularly for these highly unstable injuries. And so that's why you'll see a mix. So partially threaded first, I would say every time. I can't think of an indication of putting a fully threaded then a partial thread afterward. So you're always going to see partial thread compression of the fracture site, then a fully threaded screw, maybe to back it up for some additional fixation. So this is how this patient was treated. This was done through 2 incisions that were about this big. It's just absolutely fantastic. This patient, next day, sitting up, eating breakfast in bed. Trauma is amazing. That's all.
Excellent. Yeah, that just shows that evolution of how far things have come for sure. One of the things I want to highlight is you talked about putting in traction, and that's a skill that the students will really need to be familiar with Dave, can you talk to them about how they put in traction? What's your preference for an injury like that vertical shear? Are you putting traction in the tibia, the femur? What's sort of the protocol at VCU?
Yeah, so always think with traction, with either of these, right? We're crossing joints. And the further away we get, the more stuff we start crossing, the greater the chance that we are pulling through something that has some sort of injury that maybe we didn't recognize initially. So, you showed that x-ray, the vertical shear, this displacement of the right hemipelvis in this patient. All that you started to allude to it, all of the energy was seen probably by that entire right limb. And so there's a high incidence of, coinciding injuries, whether that be, a calcaneus fracture, an intra-articular fracture of, pilon, tibial plateau, distal femur, ligamentous knee injury. And so if we're choosing, let's say, proximal tibia for the pelvis, we're pulling through a knee joint that may have some injury. And so my personal preference is, if it's available and if it's safe, to go distal femur for pelvic and acetabular related problems. Tibia is probably the next best step, but you do want to at least check and make sure that you have appropriate radiographs of these areas, and are being alert for, patients with large hemarthrosis, large effusion, things like that, clues that could say, there may be more going on here than maybe I originally suspect.
Yeah, I agree. I think you're sort of losing your effect as you pull through more structures for sure. And I've seen that happen. These are just some fluoros showing that placement of those screws. And once again, we're restoring anatomy and stability. These are other classification schemes you may hear about. Tile is a stability-based classification. Denis is an anatomy-based classification. It shows the zones of that sacral fracture that Dr. Mitchell talked about, that zone 2 injury being higher risk for a nerve injury right there based on that sacral fracture we saw just a second ago. Going to fly through these next two cases a little bit here. This is late 60s female who fell down one step. The pelvic ring looks pretty benign, I'm going to be honest with you, but she can't walk. And so that's a concern for us in geriatrics. But way back when, we talked about hip fractures and how we want elders to walk as much as possible. At 60, I wouldn't say is that old, but sometimes patients are still osteoporotic based on some of their other medical comorbidities. So this shows the ghost recon, or these are just 3D recon images. You can see there's fractures in the ramus on the right side, superior and inferior, and then a pretty comminuted sacral fracture on the CT. You can see there a different representation of this. The ramus fracture itself is actually segmental in nature, suggesting maybe more instability. And then sometimes what we do is we seek disease. We look for instability in the ring when a patient can't walk. And so in this example, you can see as the pelvic ring is stressed, there's a lot of movement there. And you can imagine that hurts when you try to walk around on it. And so in this example, Dr. Zolzer, you put in a similar construct to the last one that Dr. Mitchell used after doing this exam under anesthesia. And how did the patient do afterwards?
Yeah, this is sort of this is a pain control procedure. I mean, imagine, every time you roll in bed, move, shift, try to get up maybe and walk, you have this macro motion of the entire right hemipelvis that we're recreating with really just about, 10 pounds of internal rotation force on the greater trochanters. And so when you restore that stability, it really helps early pain. It prevents late deformity. And that's important also for things like GI function, leg lengths, sitting balance, things like that. And so it prevents long-term problems for sure, but a lot of the initial benefit is just those first few days and weeks of getting comfort, not having the nurses having to come by and dose them with a bunch of opioids that can cause delirium, let them get up and out of bed. All those things we talk about in elder care to try to limit their risk factors, because just like you said, this is just the other side of the hip, but the same principle should apply just like it should for anywhere else on the body.
For sure. The next example is similar. It's also a lateral compression injury, like we talked about in Young and Burgess. This is a late 40s male who fell through the attic. And this results in an injury somewhat similar to the last one, maybe not quite as much comminution in the sacrum and not a segmental ramus. And the ring architecture is largely intact. This person elects to proceed with non operative management and goes on to heal and has no pain with normal activities at 4 months. So it's really a spectrum of injury, and there's a lot of nuance to the care of some of those more subtle lateral compression type injuries. And that's a big debate that's ongoing, I would say. But it's important to be aware of some of those nuances for sure.
I would
We want to
just,
get to the, oh, go ahead. Go ahead.
I
Yeah.
was just going to say, Taylor, real quickly, those last two examples, we see a pelvis with very little deformity and not obvious instability. And so that's why we do things like stress exams on those patients. Patients like this you see here, or any of those other ones that we saw earlier, those are patients with radiographically obvious instability, even just on their AP pelvis. And so we don't need to push and do stress exams on those patients. We already know that they're unstable injuries. In the two examples preceding this one, we're trying to detect instability in patients that really have much more subtle injuries.
Yeah, this one's clearly not that. And so this is a really traumatic injury, as you can see here, and probably one of the more extreme examples that you might see. And so, when you see this, it's hard to imagine this person even survives. This is a combination injury for sure. It's open. And so we are very concerned about getting good debridements, getting control of hemorrhage, getting appropriate antibiotics, tetanus, all that stuff that we've talked about in the past with open injuries. To kind of run through this one quickly, what's sort of the thought process as quick as you can with this one, Dave?
Yeah, I mean, so you talked about the team approach to trauma, and this is a team effort. You need a lot of different people with a lot of different skill sets to sort of all be on their game, doing the right thing. And so when you see, this is our job, the deformity maybe, but you see this terrible soft tissue injury, that the bowel contents, the fecal stream, people call it, is going to go into that area and contaminate the wound. So if you see here, you get help from this is an all hands on deck, colorectal surgeons, urology, general surgery. And so you see in that image on the right, you see a diverting colostomy. So they do a colostomy and keep it up and away from where all of our wounds are going to be, to get it away from all these traumatic wounds, so that there's no bowel contents spilling this area, and we can try to get clean wounds. The colorectal surgeons, make sure there's no rectal tears. The general surgeons are there. The urologists help to repair the scrotal and urethral injuries. And then, we help with the skeletal injury. And so everyone gets to play on a patient like this, and has to be really on their game to make sure this patient lives. And he actually did pretty well. Believe it or not, this pelvis healed. He did not get any infection of any of these traumatic wounds you see at his pelvis. He did get a non-union of that right femur. And so, about a year out from this injury, he's up walking. He did need another surgery on his right open femur fracture, but otherwise he's really kind of getting back to life. And it's really a success story. And, it's one of those patients, he's a real nice young kid, 19 years old, on a motorcycle. And it's one of those things that kind of really grateful to get to do this job when you have a nice person like this that you help.
That's all I can say. We're not worthy. That's a really remarkable work on that one for sure. So that really shows the spectrum of injury. Phil, any questions that we need to hit, because we're time's certainly dwindling?
Yeah, there are a few things, and I think if you leave it on this X-ray, we'll be able to hit most of it. So we had one question about placing sacroiliac screws. And if you get the chance to scrub into these cases, it's really just a tremendous amount of fun to do. But the question was, how do you do it without avoiding nerve damage? And so if you look at this X-ray, going back to what Taylor's anatomy at the very beginning, you can see the neuroforamina in the sacrum where the nerve roots are traveling. So basically, we're avoiding those nerve roots by placing wires and then screws on our inlet and our outlet views. And so kind of coming back to some of the earlier principles. So the landmarks are often neuroforamen. There are some other landmarks that we use that we love to talk about, way too in depth, but a lot of fun. You should consider doing a trauma fellowship. The second question was about doing transsacral screws. When do you do transsacral screws and when do you do just iliosacral screws? I mean, these are just unbelievable. This is what we geek out on for hours. Usually transsacral screws, worse bone, worse injury is when you're going to see it. So when we need more fixation, going to take longer to heal, higher risk of fixation failure, you see transsacral screws. Boy, they keep coming. So for patients that heal non-op, the surgery decrease their return to work at any appreciable extent. Such a controversial topic we're not going to dive into. There are certainly patients who benefit from screws. It's a spectrum of stability. And then the last one was a great question that comes up at conferences sometimes. For a fully threaded screw, can you, and I'm gonna ask Aker to answer this one. So the question from Cesar, is it a surgeon's preference to using a partially threaded screw as a lag screw, or do a fully threaded where you pre-drill the bone to act as a lag screw as well? So you would drill, over drill near side, do a fully threaded screw. Why are we doing the partially threaded screws more?
Yeah, that's a great question. I think in general, it's just ease of insertion rather than swapping out different drill bits. And you can imagine these screws in the back here are probably 7.0, 7.3, 7.3 millimeter screws. The 7.3 millimeter drill, that's a pretty giant drill bit. So in general, it's a single pad, it's a wire, it's a cannulated drill, and then a cannulated screw. It's just you get on the algorithm and you stick to it. I think other times where you may see folks using lag by technique would be perhaps in a posterior malleolus, where you really want to maximize the number of threads that are pulling across a fracture. But those are great questions. And as you get to your orthopedic rotations, good to stay engaged and ask high level questions like that. I did want to comment. I love the fact that Taylor showed a case of a non-operatively managed pelvic ring injury, because we showed case after case after case of screws and screws and screws. And like y'all mentioned, it is a real spectrum of injury. And I have certainly treated hundreds of patients over the years without surgery that have had various types of pelvic ring injuries. So we don't want to give the impression that pelvic fracture equals surgery. Not necessarily. And that's the fun of doing what we do, is determining if patients are in fact surgical candidates.
Yeah, for sure. Shared decision making is certainly an important part of the discussion with some of those gray area injuries, those lateral compression ones. Certainly not so much with the obvious ones, but a lot of really good cases, a lot of excellent discussion. Thanks so much, guys. It sounds like we covered all the questions too. And so just a quick plug for next week's session. We'll skip over that summary. Don't forget to get your badge. Next month, we're talking polytrauma. So put your thinking hats on, because those can be challenging clinical situations where patients are multiply injured, physiologically compromised, and then have really complex injuries. And you start to have to think about, which do you tackle first? How do you position? Lots of different variables. It becomes challenging fast. And so we're going to have some good discussion there as well, certainly. And so thanks for joining us, Dr. Zulzer. And thanks, everybody. And
you say real
Taylor.
quick.
Hey, Taylor.
yeah.
I'm gonna put a bug in. Thanks, Dave. So I'm gonna put a bug in Aker's ear for this next one, because I'm curious. So this is we'll go over this case next time. So young gal, open tibia on the right, type 1 open tibia, left comminuted femoral shaft, first TMT fracture dislocation, and then this complex pelvic ring, vertical shear, about 3 centimeters displacement in the back. What you doing first? I'm just gonna lay it out there. Don't have to answer. Taylor, I'm gonna ask you too. I started with the toe personally, but we'll see what Akers wants to do.
Well, I just know you love pinning toes. So
On a Friday night, usually about 7
yes.
p.m. is when I like to do that. Yeah.
Yeah, you know,
Me
this
too,
is
me too.
just right in my wheelhouse. Like you said, if the students are interested in this kind of stuff, they should definitely do a trauma fellowship in Houston or Vanderbilt or wherever they choose. because this is just so much fun to talk about. And I mean, for me, it's all, everybody wants to look at the x-rays and immediately talk about X-fix, or I can nail one long bone or nail two long bones. And like, do we just wrap the pelvis up? What about the physiology? What about the lactate? What about the resuscitative phase? What about the gross contamination in the wounds? What about the H&H? Is she bleeding? There's so much more to talk about. So unfortunately, Phil, I can't answer you just based, I don't treat x-rays. I don't treat x-rays. I treat patients.
Love it.
Yeah,
Love it.
that's a
So I'll
good
see you
one.
next month.
Yeah, good one to end on there. Thanks, guys.